Yep, it's live now. Thanks, Terry.
Okay, thank you. So good afternoon, everyone. Welcome to March Governing Body. So we shall get on to the first part, which is our welcome and introductions. So we've got quite a busy agenda this afternoon and a limited amount of time. But we will, as always, try to ensure that we have plenty of robust debates around all of the topics that we've got on the agenda this afternoon. So I've had apologies for absence from Judy Robinson and John McElwraith, and at this stage there've been no further apologies for absence notified so far. I can confirm that the meeting is quorate, but I'd just like to cross-reference that with Kath. Are you happy that we're quorate and we're ready to go ahead? Thank you. So next item is declaration of interests. So could members of governing body declare any interests that they've not declared so far on the register or that are specific to today's items? Okay, I'm seeing no new declarations of interest being brought up.
Terry, can I just come in?
Yes, please, Kath.
Yeah, Zach, do you need to raise one in relation to the item on the Talbot Trust?
So, Zach, we have you on mute at the moment.
Sorry, it helps if I'm not on mute. I'm a trustee of the Talbot Trust.
Okay, thank you. And we'll be making a decision about future trustee arrangements. So we note that, and the actions that we'll be taking there is, Zach, you'll not be a member of the decision making at that point, but we will allow you to remain present for the conversation if you're comfortable with that.
Yeah, thanks.
Thank you. Thank you, Kath, for raising that for us. I have not been notified of any questions from the public, but before we go ahead, can I confirm that with you, Jackie, that we've not received anything in the last hour? So no questions from the member of public. Thank you. So, as I say, we've got quite a busy agenda, and my plan is that we get straight into that if we can. And the first item that we have on the agenda will be the approval of the minutes from the previous meeting held in public, which was on the 14th of January. In the interest of time, I will take them page by page, and if we can notify governing body of any exceptions or corrections that anybody has. So I'll take pages 1 and 2 together, pages 3 and 4, pages 5 and 6, pages 7 and 8, 9 and 10, 11 and 12, 13 and 14, 15 and 16, pages 17 and 18, 19 and 20, and finally 21 and 22. And noting that page 23 of the minutes is a list of abbreviations used in the minutes. Okay, so no corrections have been brought up thus far. So governing body will accept the January minutes as an accurate reflection of the meeting. So I'll now move us on to actions and matters arising from governing body meetings held in public. So first item we have is item 122/19 regarding a question from the member of the public with regards to vacancy and staffing across our patch. Brian, is there any further update on that for today?
There isn't any further update today, Chair. Sorry. The group still isn't active because of the current sort of situation. So that group isn't meeting yet, but the action will still remain live until such times as it does.
Okay, thank you. Item 9920 regarding the sponsorship approval for any sponsorship above £5,000 from pharmaceutical companies. I can confirm that the sponsorship has now been picked up by another NHS organisation in the city. It leaves us with the question about how we take forward any commercial sponsorship. However, given the future proposals for structuring of commissioning in the future, we feel that this may be a conversation that would be better had across South Yorkshire and Bassetlaw, with a view to having a commonality of approach. And for that reason, we've now recommended that as an item for closure for governing body. But if any further approval or any further papers come forward, then we will bring those to governing body discussion. So, Zach, is there anything further that we need to add to that?
I think that's probably pretty much covered it. Thanks, Terry.
Okay, thank you. So item 116/20 links to what we've just said, and that's now recommended for closure. So item 137/20 is around the revised operational plan and commissioning intentions, which we will be discussing later today. So is there any further update on that beyond it coming back to today's discussion, Sandy?
No, Chair, I think this is about a patient's story. I mean, it's got two other names next to in terms of the lead. So I'll pick up with Kath outside of the meeting if there's no other update from Kath.
Okay.
I think because we've had apologies from John, he's going to come and update at the next meeting. So.
Thank you. So item 521, which is future agendas for governing body meetings held in public. An amendment to the email address, which was pointed out to us, that has now been completed and the item's recommended for closure. Item 721, regarding the patient's story, the thanks from governing body has been passed on to the groups involved. That one is recommended for closure. Item 1021 regarding the governing body assurance framework. There are a number of elements there that have now been recommended for closure, and we do have open action on that regarding the GBAF. So Kath, could you just update us on where we are with that, please?
Yes. So we've completed the email circulation. We had Anthea, Morris and myself had a discussion about what to put into the next report. So we can close that and it will be reflected in the next report that comes, as will I think it was including the objectives alongside the risks. So that's be doing, and that's in fact going to audit committee with that in it as well. So we've already changed that.
Thank you. So we'll recommend that item now for closure, and we'll see the updated version of that document coming into governing body at our next meeting in May. Thank you. So item 31/20, which is our month 8 performance and delivery report. All items are now recommended for closure on that one. Next one is item 15/21, which is respond to the chair of Healthwatch via the CCG about dental health and clear information that could pass on to people. This is something which Eleanor Rutter, consultant in public health, was going to make a response. Given that Judy Robinson isn't here, we can't confirm whether that's been received by Healthwatch. I wonder, Greg, whether you've any further information on that, or whether we pick that up next time.
No, pick it up next time. I asked Eleanor, but she's on leave this week, so I can't get a definitive answer from her one way or the other. So I'll chase up after the meeting.
Thank you. And then item 1721 regarding our accountable officers reports on system and place partnership. There was an offer there to pick that up offline. Leslie has indicated that the documents are accessible through usual communication channels, and that item has been recommended for closure. Okay, so next item we have on our agenda is our patient story. We usually have one of these each month just to help us focus on what it is we're really here to do. And I'll pass over to Alan Windle to introduce the patient story, please.
Thank you, Chair. I believe Lucy is going to share the story now. Thank you again to governing body for listening, but I think personally and from a governing body perspective, as usual, I think, Chair, the action would be to thank the individuals involved in showing some of the complexity from hard to reach groups and disabilities on how we interact from a health care perspective, and support the advocate's view there that the daughter was put in a position really of being the interpreter, and that, you know, not considering what the daughter was actually hearing herself before doing that, undertaking that advocate type role. I think for me, there is definitely some actions from this patient story that I think we really need to pick up, both personally, I and Lucy, to meet outside, to how we engage with our commissioned providers, all commissioned providers, and how we utilise this story and share this story with the director groups across the city on our commissioned providers. But I also want to say a big thank you to the Deaf Society and Blind Society in Sheffield, who have supported us, particularly within the COVID programme of assessing access to COVID sites and sharing with us some of the complexities. So I am a little assured that we've had some of that input from such advocates to ensure that our sites have considered, but this is generally more of a broad-based healthcare provision rather than just detailed on COVID, I would suspect. And happy to take any views from governing body members on that patient story.
Thank you, Alan. Judy, please.
Yeah, I'm really glad that this is being shared at governing body. I have actually seen it before, and I think the impact and thinking about actions, I agree with the actions that Alan's outlined. I think also we need to take this to our quality committee too, so that we can further look at this, because I can't imagine what that was like for, well, any member of the family, but the daughter in particular, hearing that information for the first time. And I think what strikes me is that we need to get to the point where clinicians and anyone within hospital, primary care or any health service think, this person doesn't hear, doesn't see, doesn't use words to communicate. What can I offer? What do I need to do? Rather than the person having to, raise the question. So yeah, I think we need to take it to Quack, Alan, as well.
Thank you, Judy. Mark Gamsu, please.
Yeah, thanks, Terry. I knew this was at some point would come to governing body, but I wasn't aware it would come today. So I need to declare an interest as chair of Citizens Advice Sheffield, because it was our service, and you saw Kate speaking on that, that produced the video in partnership with Healthwatch Sheffield. just a couple of things. You know, don't have to tell anybody on this at this meeting that NHS services are under huge pressure. But nonetheless, I think it is unacceptable that somebody who's deaf should have experienced this at this time. And so I think I'm glad that this issue is being taken up by the CCG, and I welcome Judy's comments. I would say that the former chair of the Deaf Advice Service, who is now on our trustee board, because Deaf Advice Service is now part of Citizens Advice Sheffield, who is a deaf person, was, and I can fully understand this, she was so angry when she heard this had happened, because the deaf community has been campaigning around these issues for years. And to then have this example of where a major institution in the city has not been able to pick up on and change its organizational culture to see this as a priority. As I say, I think, you know, justifiably, she was upset and angry that despite years of discussions and, you know, genuine collaborations with people, that it's not been created embedded change. So I think it's just, you know, unfortunately, and I think it's really important the story is here, but it's a sort of salutary message to us that if, you know, we're going to move forward, there is still unfortunately plenty of work that needs to be done, but it relates to other issues that are on the agenda today. For example, our understanding of the information that we have around people with disabilities, for example, using NHS services, and we'll pick that up later on. But I think it also relates to some of the concerns that we are hearing in the media and we're concerned about, for example, which is the relationship that excluded groups have with health systems, which then affects their willingness to take up vaccines and so forth.
Thank you, Mark. Marion, did you have your hand up?
Yeah, thank you. My view is there's no excuse for this, and it's a disaster that clinical scenario got as far as the doctor, the consultant, and nobody in the whole team had flagged it up, because that should have been flagged from the very beginning. It is not difficult to get a deaf interpreter. It's not difficult to get a sign interpreter. The same thing is for a Chinese person and an Arabic person. They need help to get the best out of their medical consultation, so that by the time you get in there with the doc, you've got 20 precious minutes that you need to get every grain of information, comfort, whatever out of it. The daughter there was most definitely on the back foot. She was thrown into a grief situation. She should not have been asked to do that, but she was, so she did the best that she could. So it's the doctor should have said, right, let's stop now. We will get some help to make this a meaningful consultation, but they didn't. So really the whole team needs education. And this is the key to it, that the receptionist, everybody who was involved in there, all the paperwork from leaving the GP right through, didn't get that message. It needs to be flagged up in a very noticeable way. We had an example here at the practice yesterday with a locum, and I know this guy's deaf, and he booked him in for a telephone consultation. Totally inappropriate, complete waste of everybody's time, but he didn't know. So we're looking at our records now to see how the computer records can be flagged to say this person has a special need. You know, there's a way this can be done. And the hospital is just the same as primary care, but it's a much bigger machine. So it's going to be more difficult to get those messages to all the staff involved.
Okay, if I may, just in the interest of helping us through the agenda, just take two final comments from Lucy and Andrew, please.
Thanks, Chair. I'll be quick. Just to reassure governing body, there are issues with the current contract, and we share the same provider as STH, and we are re-procuring the contract, but that won't be till September. So we're working internally, like Alan said. We're meeting to look about what we can do outside of the contract, and we'll do that with our partners. And it comes down to training and education, and it comes down to, like you say, the records, which everybody has a legal duty under the Accessible Information Standard to have it recorded on a record that somebody's deaf. So there are these things that we can do before we procure a new supplier or a new improved contract. It might be the same supplier. But I thought people would want to know that.
Thank you, Lucy. Andrew, please.
I was just going to sort of, on top of what everybody else has already said, to say that to me this points to everything we aspire and know we want to aspire to be doing in terms of patient-centered care and support and shared care records and shared technology functions, that an integrated care system, this just couldn't have happened, not shouldn't have happened, but a system that couldn't let it happen. And we just kind of need to, and it's good to hear everybody recognizing that. And you know, I think we just need to redouble our efforts on all these different elements and make sure they all come together really.
Thank you. So a final reflection, just bringing in all of that together, really. This is, for me, a really powerful story that, you know, is spelling out a big inequality, spelling out a story of isolation, a story of not having the right support in the right places, and a story of grief, but also the importance of those support organisations that we have, and that we should be using in the most appropriate place. So as we always do, we will pass our thanks on to the people involved in making that video, but kind of make a request of the communications back is that we do those in a way which is most appropriate for the people receiving the message, that we don't necessarily just put that back in writing as we usually would with anything else. So can we make sure that we're mindful that we communicate in the best way for the person receiving it? Thank you. Okay, I'll move us on now to part 2 of the agenda, which is our papers for approval. So first paper is item 8, and that's paper C in the noting pack, and that's our communications and engagement strategy. So I'm going to hand over to Brian to introduce that, please.
Thank you, Chair. And all I will do at this point is introduce Lucy, who needs to take the credit for the strategy which has been written. It's been written for some time. Then a pandemic got in the way, so our ability to take the strategy out has been somewhat constrained. But what we also want to highlight today is the work that has continued even since the strategy was written. So Lucy, can I introduce you and ask you to take us through some of the highlights in the paper, please? Thank you.
Thanks, Brian. Thanks, Terry. I'm Lucy Estridge. I'm the Deputy Director, Communications and Engagement and Equality for the CCG. I'll take the paper as read, but I'll just, I think, spend a little bit of time just talking about the context. So this is a new strategy, and it's building on a strategy that we had in 2016, and it was developed well over a year ago, the end of 2019, and it was ready to come to governing body for approval sort of Easter last year, and we had a plan of engagement with Health Watch and other community organisations in the city to get their views, but it was all postponed because of the pandemic. So it was written a year ago, and due to sort of capacity issues, it hasn't been massively refreshed since. But I think the reflection is that it still stands a year later in the sort of, I can't say post-COVID world, in the a year into the pandemic. But it's here today for approval. It went to speak in February and it was approved there. And we have engaged internally, we've engaged the staff forum and deputy directors to get their view. And actually, in terms of the engagement side, we do regular engagement with the population, and we did a piece of work with neighbourhoods, and we asked people then their preferences for communication, how they want to communicate with the NHS and be engaged. So that's all being reflected in there. And just to say that we haven't rested on our laurels this last year, we've actually as an organisation lived and breathed the strategy. And there's lots of things that actually, it was originally going to be a 3-year strategy and it's now a 2-year strategy. And there's so much that we've delivered already. The vaccine engagement and comms is, I think, a really good sort of pertinent example where we're actually investing and funding community groups to do the comms and engagement on our behalf and actually co-produce that engagement because they know how best to get to those community groups. We're doing it through the lens of health inequalities. So in the strategy, you'll notice, you'll say that our vision is to involve people in Sheffield and our decisions, especially targeting those with the greatest health inequalities and those in the poorest health. And for the last year, in terms of engagement, We've done the engagement work around the impact of COVID, very much focused on those communities, which has shaped our commission and intentions and actually shaped a lot of what we've done in the organisation in the past year. And there's lots there that we've done around comms in terms of we're now producing more videos. We're kind of already delivering the digital side. We've done lots of campaigns. We've done the urgent care campaign, which was a really good, effective campaign, but unfortunately we couldn't do all the evaluation because of COVID. So hopefully you will recognise that actually we've done a lot in the year, and you will still think that it is relevant and future-proof for the next year of the organisation. It does bridge the work, it does bridge move into a digital world, but actually keeping a focus and putting our resources into those people that are digitally excluded and those that have the greatest health inequalities, working with the voluntary and community sector, and it is aligned to the future direction with the ICS, working at system and place. We talk about all the communication organisations in the city communicating in one voice. So that's all there. It just perhaps doesn't have the level of detail and the much of a refresh as I suppose would have been ideal. So I'm happy to take any comments and questions.
Okay, thank you, Lucy. So this paper's come to governing body for approval, noting that there's been significant input on this before it's come to governing body via Speak. So I'll open up for questions and comments. So first one from Greg Fell, please.
Thanks, Chair. So thanks, Lucy. Really clear and coherent presentation, really clear strategy. Just a brief comment. I hear a lot from members of various communities, particularly in the east of the city, but not exclusively, that the sort of the messages that get out to them are very clear, very coherent, and they really, really appreciate that. And secondly, I hear a lot of really positive feedback from our comms team within the council about the joint nature of the comms work, particularly around vaccine uptake, which is the thing of the moment. It's very, very, very much appreciated, and thank you to you and your team for making it so.
Thank you, and thanks for that feedback. I appreciate it. And I'd say the pandemic has actually helped sort of forge and escalate some of those relationships and partnership work, and it has helped in sort of uniting and coordinating the work in the city. Yeah, thank you.
Thank you. Leslie, please.
Thank you, Chair. I think it would be remiss of us as if we didn't note one of the points in the paper, which is the outstanding rating for our engagement work, and to say thank you to Lucy and the team for all that they're doing. Building on what Greg had said earlier, it was a joy to me to be at the Regional People Board last week, and again hear mention of the work that we're doing in Sheffield with BAME communities. So that was great as well, and thank you for that, Lucy. As we go into a transition year and a period of change, it is really important that we build on and embed in place the things that are very important to us. And we've been speaking to staff about co-designing, how some of the key work and functions we deliver will work in a future world. And I just really want to emphasise we need to be quite careful and mindful and indeed bold about how we land our engagement work for Sheffield and Sheffield citizens going into the future, and embrace some of the opportunities that are there to seize from that.
Thank you. And actually, I should have said in my presentation that we have a Speak workshop planned, I think at the end of March, and Health Watch will be involved and Council will be involved in the ACP to try and build on like the current model, thinking about the strategy and thinking about where we take engagement in the city, and very much not starting with a blank piece of paper.
Thank you, Lucy, and music to our ears, hearing that integration with our colleagues in provider organisations in the voluntary sector, and also with our council colleagues in the commissioning world. So really pleasing to hear that. Chris Neild, please.
Yeah, I'm a lay member. I just remember I need to introduce myself. I echo what people have just said, but I think particularly for me, there's been such a proactive approach and learning that's been built on, and particularly starting for me with the urgent care and really making a difference to bringing the voice into what we did next. And also over COVID, those links and getting a real understanding of what communities are thinking, what their understanding is of the situation. And that again has been reflected in those key messages. And just latterly, the issue about the role of engaging the staff and our cultural change and organisational change. It's been built on those foundations, and I think will stand us in good stead as we go through the next changes to come with the ICS and so on. So thanks. I think it is innovative and well-deserved award. Thank you.
Thank you, Chris. Mark Gamsey, please.
Yeah, thanks. So Lucy's okay. I endorse. I'm really pleased to hear other people, other than someone like me, who's the chair of Speak, complimenting this work. And so I don't. It's really good to hear it. I think Lucy mentioned at the end that it's not in the strategy, but we have got this workshop coming up at the end of March, which is we're hoping that it's open to all members of Speak committee. And that's starting to think about how can we, in good order, how can we build on the good practice in the city, and how can we ensure that our learning, both of the things that worked and the things we struggled with, can help us develop a better, better system in Sheffield going forward in terms of how we work with the public and their experience to help us drive better services across the health and care system in Sheffield. I just want to stress that just because it's a small part of our workforce, the communications and engagement team actually, is actually, even though it's very small, is crucial to the success of a health and care system going forward. And clearly one of the things that we need to think about is it's no good just having the ideas, but have we got the capability and the relationships and the credibility after 2022 in place to continue to allow us to build? And I think that's one of the things that we're really, need to be giving some thought to. I noticed, and I can't remember, there's so many papers on this in the next agenda, that there's in one of the papers for noting, it sets out 4 areas that the integrated care system is focusing on, 4 work streams, one of which is place. And I do think that how we engage with that work stream and are invited in, and I know Leslie will be thinking about this, is going to be really important to ensure that we embed those relationships and the skills and experience that is required to actually make that happen.
Thank you, Mark. And I'll take one final comment from Andrew, please.
Thanks, Lucy. It's a really kind of thorough, comprehensive read. So 2 bits I was wondering about, to some extent, and it's a bit like Mark sort of saying that kind of future-proofing thing going beyond 2022. And so I know it sort of talks about, millennials to baby boomers, which captures Gen X, but what about Gen Z, who are currently kind of aged 6 to 24, and the fact that they all think Twitter and TikTok and Facebook are for old people? So how do we capture that kind of younger emerging connection? But also, by the same token, if we're using these tools, do we need to think about digital security around our communications and engagement? The recent changes to the WhatsApp terms of reference and things like that, and data, and protecting ourselves from a misuse around fake news and things, if we're going to use these platforms more and more going forward.
Thank you. I mean, Generation Z are definitely included, and I think the strategy does say that we need to keep afresh of what's going on in the latest trends, because it's changing all the time. Like you say, I think when I started writing the strategy, Snapchat was popular. Now, kids have moved on to TikTok. Parents now use TikTok. So it's keeping up with the latest digital technology and actually targeting it at the right audiences. So yeah, that's one of the challenges, but something we definitely focus on. And digital security, yeah, we're always mindful of that, and think, yeah, we will look into it.
Okay, thank you. So this paper's come forward for approval. So our governing body approving this paper, if we can all just thumbs up or nod at that point. Okay, not seeing any dissent from that. Thank you, Lucy. So I'll now move us on to item 9, which is paper D in the noting pack, which is a review of quality assurance committee terms of reference. And I'll hand over to Kath to introduce that, please.
Thank you, Terry. So the purpose of this paper is to ask governing body to approve the proposed changes to the Quality Assurance Committee Terms of Reference. In January, you'll remember I came with lots of papers as part of the Constitution, and that included terms of reference from our committees, but QAC wasn't in that pack because it was delayed due to COVID pressures and because of introduction of the new chair due date. So we brought that now. I have spotted, and have we got Alan there? Right, you're back. I've spotted and I've had a bit of a conversation with Alan today because it's got in there an associate director of commissioning in attendance bit, and we don't have one of those, but I think we might have done in the past. So Alan, do you want to just say what that should be, and then we can make
yes, apologies, because I do keep on getting kicked out of Zoom for some reason. So if I'm not here moving forward, I will be back. Yes, unfortunately, that is an error. The Associate Director of Commissioning. I think what we do need, Kath, is a representative of commissioning, and happy for us to change that line and then work with Sandy to look at who would be the nominated individual title to go into that terms of reference, if that's okay.
Thanks, Alan. So really, what I've spotted just by looking through it is that there aren't that many changes to the terms of reference. It's moved from monthly to 6 weekly, and it's got the addition of the public health representative. I don't know if there's anything else to add to that, Alan. Does that cover most of the changes? So it's pretty straightforward, isn't it?
It does, yeah.
Okay. So I think that's all I need to say, really.
Okay, thanks. Thanks, Kath. Just to note, I think it's gone from quarterly to 6 weekly in the terms of reference, given QAC was a quarterly meeting. So just for completeness there. We're probably not going to need too many questions and comments on that. I think we've just clarified that role in the conversation, but I will open up to governing body if there are any final points I would like to make before we approve the paper. No, okay, so governing body is approving the updated terms of reference. Thank you. Now move us on to item 10, which is paper E, Talbot Trust and the appointment of nominated trustees, noting the conflict of interest that was raised earlier. So Zach, we'll allow you to be present for this one, but we won't involve you in the discussion. Thank you.
Okay, thanks, Terry. So this report is requesting CCG to consider extension of the appointment of a nominated trustee to the Talbot Trust, and it's been produced by Jill Newman, who is clerk to the trustees of the trust. So just for those that don't know, and I didn't really know this till recently, the Talbot Trust, it's a grant-making registered charity that distributes funds to support health-related charitable work for Sheffield residents and those around near Sheffield. And the most recent organisations that are funded are in the paper in the appendix, if you want to look at the details. The trusts have always maintained close relationships, and it's Sheffield CCG who's got the authority to nominate 4 of the 8 trustees for 4 years. And they have responsibility for the work of the trusts and responsible for their actions and body to the regulator, which is the Charity Commission. So Dr. Zach McMurray is one of the CCG nominating trusts, and we're asking governing body to extend the appointment by 4 years to the 9th of December 2024. You might have spotted that we have actually missed a few months out in the time, but if we agree to this extension, it will cover that period from the 10th of December onwards.
Thank you, Kath. Kath, I'm getting an echo, so I'm going to put you on mute. Thank you. Fairly straightforward question for governing body. Are we happy to extend Zach's tenure as our representative, our nominated person on the Talbot Trust? Perfect. Congratulations, Zach. You may now speak again. Thank you. Okay. Right. On to our next item, item 11, paper F, mental health investment standards, our statement of compliance. Over to Jackie Mills, please.
Thank you, Terry. Again, this is a relatively quick item. Governing body members will be aware that we're required to produce a statement of compliance with the mental health investment standard. So the current year we're looking at is 2019-20. The auditors are well into the audit of this standard, but one of the things they do require from us as a governing body is a letter of management representations. That the example is appended to the paper, and I'm asking for approval for Leslie to sign that on behalf of the governing body.
Thank you, Jackie. Again, I think it's a fairly straightforward question for governing body this afternoon. I'll open up in case anybody wants to add any other comments, but no hands going up at the moment. So as a governing body, we will approve that Leslie can sign that management letter, or management representation letter rather. Okay, item number 12, paper G, is the CCG financial plan and initial budgets. And back over to Jackie, please.
Thank you. This item might be a bit longer. The purpose of this paper is to bring two things to the governing body. So the first is to bring an update on the development of the financial plan, and that, as the paper describes, is in the context of having very limited planning guidance. So we would normally expect by this stage to have lots of information about how next year looks, and also in the absence of any confirmed allocations from next year. So noting we are 4 months away from the start of the financial year, it is a fairly exceptional place to be. The second point of the paper is to actually ask governing body to approve some initial budgets. So it is a requirement that governing bodies sign off initial budgets before the start of the financial year in order that we can start committing expenditure in the new year. So the key issues I just want to bring out in terms of the paper before I hand over to any comments or questions. As I've said, the national planning guidance has been delayed. So nationally, it was confirmed due to the need to focus on responding to the latest wave of the COVID pandemic. Planning guidance wouldn't be issued. And we also had confirmation that at least for the first quarter of the next financial year, the existing financial arrangements where we have block contracts and centrally set financial plans would be rolled forward. They are saying for at least first quarter, but there are increasing indications from national calls that is likely to be in place for at least the first 2 quarters of the financial year and potentially for the full year. You'll note from the budget yesterday there was an absence of information around spending commitments, so a lot of information about taxation and support, but not a lot of information around public sector spending. But for the avoidance of doubt, the financial plan presented here doesn't take into account or estimate what those rollover arrangements will be. So we've used historic ways of setting budgets based on previous levels of spend and activity to set the financial plan. The assumptions underpinning the plan are set out in the paper. The headline figures are that we are estimating something near £42 million increase in funding available within Sheffield. However, there are already significant pre-commitments against that funding. So, for example, we know we'll be required to demonstrate compliance with the mental health investment standard for 2021-22. We expect that the GP contract settlement will bring with it a level of financial pre-commitments. And we also will be required to fund inflation activity pressures in the normal way. The balance of these two issues is that based on the set of assumptions outlined in the paper, there is a £14 million difference between the funding that we expect to get in and the estimate of commitments. And so that would be the efficiency requirement that we'd be required to make. At the moment, we have schemes identified. Our quick programs would deliver, we estimate, around 5 million of that. So it still would leave a unfunded gap. Clearly, in the absence of detailed planning and resource confirmation, it's difficult to make any recommendations about how we would close that gap. Firstly, because the gap is likely to change. It could go higher, it could go lower, but also because we are still waiting confirmation of the financial arrangements that will be in place, and that will indicate where we can look for efficiency savings. So it is an estimate at this stage. We often start the financial year with a significant level of efficiency challenge. As I say, the difference this year is the increased level of financial uncertainty that we go into the new financial year with. And so I think the final point is just to note that the budgets that I'm recommending to be approved are outlined in Appendix A of the report. And as I said, our prime financial policies do require that the governing body approves a commissioning and running cost budget before the start of the financial year. So they were the main points, Terry, that I just wanted to draw out from the report. Obviously, we had some opportunity at our development session in February just to talk through some of these assumptions in more detail. So I'm hoping that governing body members will recognise a lot of those, but I'm happy to take any questions or comments.
Thank you, Jackie. Any questions or comments from governing body? Mark, please.
You might think I've got some challenge to try and speak to every single item that appears, but I'll stop in a minute. I just wanted to, it just struck me, and I know this won't come as news to anybody, that all of the statements around subsidiarity in the government's white paper and the sort of giving more freedom to places, one of the measures of that is, does the way in which budgets are allocated actually enable that to happen? And when I looked at this, Jackie, and in particular your fourth bullet point under key issues, I sort of thought, oh, well, that doesn't feel very freeing. So we give with one hand and then we do a mixture of taking with the other and also saying, actually, there's a whole lot of must-dos you've got to go ahead and sort out here. So, you know, the measure of sort of some of the principles in the white paper around greater subsidiarity at place and neighbourhood level, one of the tests is, does the financial environment actually enable that? And I looked at that statement there and I thought, no, it's not. But anyway, yeah.
Okay, thank you, Mark. Jackie, do you want to come back on that observation?
No, I think I'd share that as one of our key challenges. I think the challenge for us locally, though, is to make sense of where, with competing things that we would look to do, where our biggest priorities are. And I think the work that we have done over the last year around our commissioning intentions, our joint commissioning intentions, very clearly focus where we want to put to make some of those key decisions. So I think it's a very challenging position, but I think we have put ourselves in the best position possible in terms of being able to know some of the priorities that we really need to make progress with.
Thanks, Jackie. Chris Neild, please.
Yeah, thanks, Jackie and team. It's such a thorough piece of work when working on assumptions, but based on such experience. So there's a lot of confidence in this. I take Mark's point. I hadn't thought about that before, but there does seem to be in the new proposals that are top down so that we can look at the situation nationally or at least regionally at the same time as a subsidiarity at place level. So it's hard to think how that will exactly play out. And my question was about the having to find this 14 or 9 million. If it's going to be 2 quarters in, do you think it's likely that they'll have 6 months and you've got to find this extra resource if it doesn't balance, Jackie? I've lost you there.
And I think that's the most difficult question at the moment, Chris, because we haven't yet even seen what Q1 resources might look like. You'll note from the paper, I haven't even tried to estimate what the ongoing COVID expenses might be and whether there's going to be sufficient resources to cover that. I think realistically, because the providers will have levels of block contracts, the ability for us to redesign pathways and release efficiency through doing that probably are very limited, and the scope to look for efficiency savings outside that equally are very limited. So I think it will be particularly challenging once we see those final levels of resource to actually identify where we might find those gaps. So I don't want to sound too downbeat, but it's the most challenging I've ever seen it, really.
Okay, thanks, Jackie.
Leslie Smith, please.
Thank you, Chair. I wanted to go back to Mark's question and looking beyond next year, which is a transition year, and what the future beyond that point would look like. And I think there's some interesting things in a white paper between an NHS statutory board and a health and care partnership, and a health and care partnership with statutory duties to collaborate across a wide range of partners, being able to shape the direction of travel. So I think that's an interesting thing to hold on to. And equally, where will be the point of delegation in place? And one of the emerging points of delegation is our joint committee, and our joint committee with local authorities. And we touched on this last time that we met, where we have shared priorities and pooled resource to meet the needs of local people. And there's something about thinking in the future world, what freedom for local decision making might that offer up to us, and how do we maximise those opportunities?
Thank you, Leslie. Brian Hughes, please.
Thank you, Chair. And I should have introduced myself earlier. I'm Deputy Accountable Officer. I know I've spoken twice already. So that's me. I just want to sort of lend my support to Jackie. In planning's always difficult. But this year it seems even more difficult in terms of the complexity that sits behind that. But what I commend in the paper, Jackie, is that commitment of the conversations that we've already had, both as a governing body and in the Joint Commissioning space that we occupy, and where we take later our operational plan and commissioning intentions. The plans that we've been able to develop, or you've been able to develop, take us and recognise those priorities, our objectives as an organisation, and the intentions that we've got. So we have to plan, and we have to start doing something. So it could be 1 quarter or it could be 2, but that doesn't mean that we can stand still. So, you know, the residents, the population of Sheffield still need services. So we still need to be able to act within the objectives and the priorities that we've already identified. And this plan starts to take us in that direction. So in the world of complexity and ambiguity, thank you for doing what you've done.
Thank you. Andrew McGinty, please.
Thanks, Terry. So not to be a merchant of doom and gloom, I suppose maybe to kind of join Jackie in this is a real complex challenge, but as always, I'm sure we'll be up for it. Yeah, some of you might have spotted the £3 million quip on prescribing. And of course, at the moment, our meds optimization team are busy deployed doing vaccinations. And I've just before this meeting, I was in the ICS outbreak oversight meeting where there was great news about reducing rates of infection, reducing levels of admission across the ICS. But of course, if we take staff away from vaccinating to start to do prescribing quip, then we might prolong that and prolong our providers being in block contracts. And so this is going to be a real tough juggling act, getting the emphasis in the right place at the right time to do the good work, which, you know, we've risen to challenges before, and this is a tough one, and I'm sure we'll do our best again, but there's a real complex picture this time round, I think.
Thanks, Andrew. Nikki Bates, please.
Jackie, are we any different from any of the other CCGs around in Yorkshire and Humber, or nationally? Is this a nationwide picture? And if this is a nationwide picture, then we'll just have to get on with it, won't we?
Yeah, no, it is, Nikki. I was on a national call with Julian Kelly, who's the National Director of Finance, last Thursday. So I think the issues and the comments that we're having today were echoed in that call. And I think, you know, not to underestimate the level of challenge nationally, because obviously there are ongoing conversations between NHS England, Department of Health and Social Care and the Treasury. So there was one thing in the budget yesterday was the announcement about funding for the vaccination programme, which is positive, but there's still lots of national discussions to be had, which is what's limiting some of the information being shared locally. Yeah, so we have to keep coming back to it.
Okay, thank you. So we've been asked to approve these preliminary budgets here, recognising that nationally there is a lot of ambiguity and uncertainty, but also recognising Brian's words that we need to be still getting on and planning something even in the face of that, and perhaps just echoing Nikki's words, we need to just get on and do it. So with those points in mind, are governing body happy to approve this set of financial plans? Okay, thank you, everybody. So I believe back to Jackie again. You're on a run here, I'm afraid. So we're now moving into papers for consideration. So item 13, paper H in your pack, will be the month 10 finance report. And back over to Jackie, please.
Thank you, Terry. So yes, this is the position to the end of January 2021. So as I've reported previously, the ICS were successful in being awarded additional resources to support the system-wide deficit that was originally planned when we produced the plan for month 7 to month 12. So that additional funding has been shown as an increased surplus on the Sheffield CCG position. You'll note from section 1 of the report that I've moved the RAG rating of achievement of financial position to green, right? So from amber previously. So I think that is a reflection of where we are at in the financial year. Clearly, in reality, we've got less than a month to go before the end of the financial year. So the range of risks that we are trying to manage have reduced, but there are a range of risks that remain. I'll come on to that in a moment. And also the fact that additional resources have been allocated into the system. So since we agreed the original plan, we've had significant additional funding that's been allocated into the system. As I said, there are a range of risks that we still are required to manage. One of the most significant, and Andrew's just alluded to it, is our prescribing spend. We still have a level of volatility around prescribing with growth in items and some spikes potentially linked to as we've moved into different periods of lockdowns. And it will remain one of the estimates that are in our accounts at the year end. Other points I'd like to draw out from the report, you'll see that there is an activity update for SDH included on page 5. This shows that activity in January fell back somewhat as the obviously the activity from COVID increased in that period. So the normal levels of activity seen fell back from those that had been seen around September and October time. And you'll note that the growth in the inpatient waiting list is significant and clearly is one of the key issues that we will take into 2021-22 plan. I think they were the main points that I just wanted to draw out from the report, but as always, I'm happy to take any comments or questions.
Thank you, Jackie. Any comments or questions from governing body? I think you've given us such a comprehensive review there, Jackie. You have you've escaped the questions. I think one thing that is really worth highlighting is that change in the RAG rating. And I think it's testament to a strong finance team in the CCG that has been managing uncertainty for at least the last year, if not a little bit longer. And I think the fact that, you know, we have organisationally managed those financial risks and we've got towards nearly the year end, having managed those appropriately is something we should be very thankful for. So thanks to the finance team from governing body, Jackie.
Thank you.
Thank you. Okay, I shall now move us on to item 14 on the agenda, and that's paper I. This is the NHS Sheffield CCG operational plan, including our commissioning intentions, recognising that some of the commissioning intentions, particularly our joint intentions, have been discussed in public in the Joint Commissioning Committee, and governing body have been cited on those in our development session last month. So some of those bits we may not have as much detail of today, but I'm going to hand over to Sandy to introduce that item. So over to Sandy, please.
Thank you, Chair. So my name's Sandy Buchan and I'm the Director of Commissioning Development. So if I can just share my screen. Can I confirm that everyone can see those slides? Yes, thank you. Okay, so I'm presenting to governing body an update in terms of our 21-22 operational plan. And what I wanted to spend some time on was basically the structure of how the plan will be pulled together and developed, with the main aspects being the response and the impact that we've had to the our response to the pandemic over the last year, what we have been putting in place in 2021, and also the things that we are planning to put in place in terms of continuing to respond to the impact and ongoing work in terms of that. So that will be one main parts of the plan itself, and has formed a big consideration in terms of our commission intentions work in terms of the prioritisation of what we're needing to do and put in place for Sheffield. A main part of that will be the joint commissioning plan, and I'll come on to that in more detail. But obviously what we've been working up to over the last year or so is that joint commissioning priorities across Sheffield City Council and ourselves in that joint health and social care space. The integrating care document will also be featured in the plan, and how we work towards the future with our partners across Sheffield whilst delivering our intentions and priorities for 21-22. And health and care inequalities, and how our priorities and intentions will reduce the impact of inequalities, not just those that have been seen through COVID, but also those ones that we've identified specifically across Sheffield. And that will be the golden thread that underpins all of our priorities and work that we deliver throughout the year. So the operational plan structure in itself, I've detailed this, it's very similar to what we produced for last year, identifying, just pulling together who we are, what we do for just that brief introduction of the Sheffield CCG, a review of 2021 and our response to COVID, our commissioning intentions, which will include that joint space, and I'll come into more detail in a minute. Restoring services, so the recovery from COVID, building resilience and reducing the impact of inequalities, focusing on our highest priorities for quality and safety, and our workforce element and being a caring employer that values diversity and maximises the potential of our people. So that's the structure of the operational plan for 21-22. So the plan itself, and this is very much how we've been working within the development of the joint space. We will have specific joint plans that will be delivered by both the council and ourselves. And there will also be areas of work that either one of the organisations will be leading on, but the other organisation will need to be cited and supported of. So very much in that joint landscape, and I'll go into the more detail in that in a minute. But there will also be specific commission intentions and priorities that will be within our particular plans, and the same with the council. So it's recognising that there are some differences between the organisations, but we're very much also focusing on that joint space as well, so that we can ensure all areas are delivered and recognised as part of the operational plan itself. So in terms of developing the plan, the two teams across the council and the CCG have worked together to identify these actions, and also the intentions that will be presented. There is a level of detail within them that will encompass all of the programmes and pieces of work in order to then deliver them and have the impact that was intended in terms of them. The actions have been reviewed and assessed to meet local needs. So we've used engagement and feedback to ensure that that's been informed into what our priorities are, as well as ensuring that regional, national, local requirements and objectives have also been met. So the long-term plan or planning guidance, which I know Jackie has said that is now being delayed, but that will have to be a feature as part of the flexibility of this plan. The South Yorkshire and Bassett Law ICS objectives, the Accountable Care Partnership objectives, the Sheffield Health and Wellbeing, and obviously the Joint Commissioning Committee, as well as our own objectives as an organisation. So they've all been part of the prioritisation and working up of these intentions. We have 18 intentions within that joint space and 9 commission intentions that are specific to Sheffield CCG. And as I've said, the reducing the impact of health inequalities and the outcomes in order to look at how we monitor the impact of them is the golden thread throughout the plan itself. So the next few slides detail our joint plan, and these have been presented previously to governing body in private as we were developing up and taking, going through the journey of developing them, as well as the Joint Commissioning Committee, which Terry has stated already. So it is about making sure they come here in terms of that ongoing journey into order to identify what it is we want to achieve for 21-22. So I won't go through them in great detail. Obviously, this slide pulls together the two organisations' visions, objectives, and identifies those 6 priorities within that joint space. By working together, we really do for the Sheffield population want to make sure that what you need to live full and healthy lives is available to you, and we will join our workforce and resources to focus on the delivery of our priorities, and that is something we're definitely looking into in order to move those forward. But we wanted to just basically highlight what the benefits are and the positive outcomes of actually bringing the two organisations together in that joint space and aligning health and social care together. Our joint priorities will continue to respond to the COVID pandemic. That has been a feature throughout all that we do, but at the same time, we want to look at how we reduce health and social care inequalities across Sheffield, improving access and availability, and specific areas in relation to children, ensuring they have the best possible start in life, providing support and treatment for those with mental health and their wellbeing, and ensuring that health and social care is personalised to individual needs. So these detail the specific Joint Commission intentions, and as I've said, they're quite high level, and within them do contain a number of levels of detail in terms of the specific pieces of work, which organisation leads on that, the outcomes in terms of what we're trying to achieve and the impact that we're trying to make. And what I would like to say is just a bit of an example of one of those programmes, under the intention of working with our partners to adopt and develop a personalised approach to establish long-term condition monitoring and reviews to recover control and management of conditions to pre-COVID levels. So an example is that of a pilot that looks at having a one-stop shop screening service in primary care to gather annual review biometrics for diabetes patients. This has been developed within the ACP diabetes group. So it's been developed with primary care practices as well as secondary care diabetes consultants. And it ensures that when patients attend appointments for their eye screening, that they also get their health and lifestyle and well-being discussed and reviewed at the same time. The pilot is looking at targeting all those, obviously with diabetes, but also particular areas in BAME communities, as well as areas of deprivation, to ensure that they get the right support, treatment and access that they need. So it really just gives that one example on a piece of work and a piloted programme that aligns to one of the intentions within that joint space and the outcomes that we're trying to achieve. So within the operational plan, it will detail more of those pieces of work and the outcomes. The next few slides again just looks at what will be different within that joint space, and just highlighting how the two organisations coming together will make a difference and an impact. Throughout Lucy's presentation earlier, I was just thinking the alignments that we've got across all the working areas within the CCG, really just honing on making sure that we listen to the feedback and engage with the community to really co-produce the redesign of services and ensure it's embedded in the work that we do with our plans on strategy, and ensure that we are getting the impact, having the impact that we wanted with the programmes of work. So really working with in partnership with Sheffield people in designing and monitoring the work that we want intending to deliver for 21-22. And of course, also working with in partnership with our provider colleagues and voluntary sector, ensuring that all the services meet the expectations and are able to deliver what's set out to deliver. So really working in partnership across Sheffield. So they were the intentions and work that we're doing within that joint space. These are the specific commission intentions for Sheffield CCG. And these are the ones that are basically pull us into that recovery phase of the next stage after the impact and looking at the impact of the COVID pandemic. So really looking at ensuring access to services and making sure the redesign of services is what's needed at this for this changing landscape in this moment in time. I've said throughout that the impact of reducing inequalities will be the golden thread throughout all of our intentions. So all of our intentions will have elements as to how they will reduce inequalities, and a working group has been established within the CCG to look at where we need to focus our efforts. And the three specific areas that we were looking at, our main focus were deprivation, BAME and the homeless population. But that does not mean to say that our programmes of work will not also work with other areas of inequalities. And I've also put some other examples, such as the deaf community, which we have obviously had that impactful patient story earlier on, the blind community and asylum seekers. So it's not just looking at those, but obviously what we're wanting to do is make sure that we really are putting all of our focus and priorities into reducing the inequalities. And we are looking at developing an outcomes framework, and I'm aware that as part of the engagement strategy, we are developing, and the workshop, that we are developing an outcomes framework. But what we want to make sure is that the commission intentions and delivery of our priorities really do feed into that. And actually, so that what we're being told by the Sheffield population is actually what we're trying to deliver, and have that making those changes and impact. And so, apologies. So what the also one is working with our voluntary community and faith services is also a high priority within that as well. So really linking in with what Lucy was saying in terms of that comms and engagement strategy earlier. So our next steps then, I've got this bit wrong way round really, but it's an implementation and delivery plans. They're being worked up currently within Sheffield CCG and Sheffield City Council, and really within that joint space and joint delivery. As part of that, there'll be the development of the outcomes framework, which will be the golden thread throughout each of the Commission intentions for the health inequalities aspects. And the operational plan for 21-22 is considered to be submitted to governing body public meeting in May 21. Thank you. I shall stop there.
Thank you, Sandy. It's been a comprehensive overview of where we're planning our activity, not forgetting behind all of that is all of the business as usual that we have been doing and we will continue to be doing. So I'll open up to questions and comments. I think given the importance of us being a clinically led organisation, I'd quite like to hear some views and comments from our GP members of governing body, if that's okay. And also just thinking about Brian in the metaphorical space as our commissioning place leader, if you have any comments on this item, that would be helpful to hear as well. So I'll take a point from Judy, please.
Just to say, Sandy, how excellent to see that focus on outcomes and continuing to get the feedback from the population to ensure that what we said we'd do together is happening or not, and so that we can yeah, get it right, because I know we discussed that, didn't we, at the development session. So yeah, it's looking really good. Thank you.
Thank you.
Thanks. Brian, please.
Thank you. I'll try not to speak in metaphors in my next statement. But what I really like, and Sandy, we've all sort of shared the journey with you in terms of the development of this, both as a sovereign organisation in terms of our commissioning intentions, but increasingly how we work in partnership with a local authority and those joint commissioning, how strong those joint commissioning intentions are coming through. And a number of us from this governing body were in session with the Health and Wellbeing Board last week. And what I really like to see coming through from that, which is where that sets the strategy for the city in terms of our long-term ambition, we can really start to see in our commissioning intentions and our joint commissioning intentions how we're going to do that. And notwithstanding the challenge that Jackie threw a while ago about trying to plan this in a world where we don't really know how much money is coming into it, that thread from ambition for the joint health and well-being strategy, particularly where we have seen in reality through the last year the role and presence of our voluntary community and faith services and sector coming into its own, and the commitment that was made last week through the Health and Wellbeing Board around our statement of intent, which has to be more than just something that says it's really good and you're doing really well, but matched up with the commitments of what we are going to do, both as an organisation, as a partnership, and as a city. So sitting in a presence last week, talking about that, seeing it in our intentions, and now seeing it through to reality is a really important, you've used the word and I'll steal it from you, the golden thread of what we are and what we need to do as an organisation. So thank you for bringing those intentions and starting to bring those intentions to life.
Thanks, Brian. Amir, please.
Yeah, sorry, can you hear me? I'm good. Thank you, Sandy. I think it's been quite a journey, but the outcome is excellent. And just picking up on Judy's point, the one thing I am passionate about is outcomes. And I think at long last, there may be some cultural shift in looking at outcomes and having feedback loops, because nothing that I've done in the last quarter of a century to do with healthcare has ever been static. Everything needs tweaking, and we can only tweak by having these feedback loops, looking at the outcomes, and then kind of going back again and changing a little bit of it. So it looks as if you've got the structure right, the foundations, and hopefully going forward, it will improve and evolve. Thank you.
Thank you.
Okay. Lee Sorsby, please.
Hi, thank you, Sandy. Sandy, I feel like the comments I'm going to give, I've given several times because I've heard this several times, and you probably feel like you've presented this so many times, but it's worth presenting lots of times because it is, as you know, I think it's really excellent. Of course, I would champion the golden thread of addressing health inequalities that runs through this. And I sometimes wonder, do we still need to say this? But we absolutely do still need to say this. And addressing health inequalities isn't just about levelling up and giving everyone equal access to healthcare, equal outcomes, equal life expectancy, equal healthy life expectancy. But there's another strategic element to that, that if we address health inequalities in the lowest quintile of outcomes, actually everybody benefits. And from a strategic economic point of view, it is absolutely the most sensible thing to do. But that does bring me to outcomes. And again, absolutely support everything that everyone said about how important it is to look at outcomes. But we have to be mindful that these outcomes should be and must be informed. So lots of input from public health and an understanding of the timescale. So if we're wanting to address inequalities, we may not see the outcomes that we're hoping for 10 or 20 years down the line, which then brings me to, where we're going in terms of the new landscape and the ICS and who is setting the outcomes and how we ensure as a place that all this work that you've done and all the groundwork and the foundational work that this represents isn't lost. In the need for having quick fixes and seeing immediate improvements, because that way lies danger really, and it would be desperate if we lost that. So, and the only other thing I wanted to again say, as I've said before, is the vital importance of co-production. So involving the people that are going to use the services so that they meet their needs, not what other people might think their needs might be, is really important. So fantastic. Thank you once again.
Thank you, Lee. Nikki Bates, please.
I think working strategically with the City Council will make an awful lot of difference to how we impact health inequalities across the city. And considering, Lee was talking then about outcomes may not be seen for many years. Looking at children and looking at the best start in life is a really important thing, and it's the way that we can start to make those differences within a relatively few years rather than extremely long term. So I mean, I know we have seen this presentation on a few occasions now, and I think it is important that we do keep seeing it. The way that primary care is working together across the city in networks, the primary care networks and the clinical directors that are leading these are talking a lot more than they used to about this, about health inequalities and how to address them, and how we can do things on a slightly bigger footprint than the traditional, quite insular, small general practice. And I think it's very exciting, and we should be able to work together with the City Council to really make a big difference over the next few years.
Thank you, Nikki. Any other GPs want to come in? So any of our governing body GPs, clinical directors or medical director? Zach, please. And we'll get you to unmute.
I'll unmute first.
Excellent.
Thanks, Terry. Yeah, just everything people have said. This has been refined over a long period of time, and it feels as if we really are getting it right around the co-production bit, the clinically driven, the publicly declared. So I think the openness with the public about what we're going to try and achieve, but then actually being prepared to be held to account by the public around achieving it. And I think it's really important that as we move into a different phase that we don't lose that. So I think the strong commissioning with the City Council, who are publicly accountable, is really important. The strong relationship with the ICS, I think, is also really important. And then the strong provider alliance that we're we're trying to develop across the city. So I think it's just important that we don't lose it. I mean, there's a lot of expertise that we've built up over the years. There's a lot of trial and error because we've tried it, we've got it wrong, we've retried it, we've got it right. So I just think it's really important that we preserve this and that we keep being accountable to the public, which I think to me is really important.
Thank you. Marion, did you have your hand up? Marion, we've got you on mute at the moment. Don't want to miss that point.
That better? Thank you. Thank you. What I wanted to say is some of this is already happening, and I've got a strong interest in women's health and family planning. And over the last 2 to 3 years, the CCG has funded, jointly with Sheffield City, into a system that is now working really, really well in lots of different models, but across the city for the benefit of women's health. So that gives every child the best start in life. It empowers women. And it's like a chameleon. There's lots of different colours all over the city. So you can have provision at the GUM clinic at the Hallamshire, but equally well, you can have it at your own doctor. Your own doctor can refer to the doctor next door. You can have it through Primary Care Sheffield. You can have whatever family planning services you need. Greg Fell has very generously funded it so that if we want to use a particular thing, we can. We're not budget limited. So it's a wonderful, wonderful opportunity for reducing inequalities, because every woman can access whatever contraception she likes. And that is a great asset. And it's not happening. It's not happening in every city. Bolted on to that, Primary Care Sheffield has put education, and not only for the obstetric and the family planning side, but also gynecology. So in primary care, we've now got a specialist primary care service that is able to receive referrals, and that stops referrals going up to secondary care. So it's this joined up thinking that we've now got a web across the city of services close to home, tick the box for the green agenda, that is second to none. And in terms of outcomes, I don't know, I haven't seen the termination figures and the unintended pregnancy figures and things like that, but I'll bet you anything, Sheffield will measure up to any city. And it's thanks to good thinking, forward planning, and basically financial investment from the CCG.
Thank you, Marion. What a good example of integration at work.
Yeah.
So thank you for highlighting that one. I'll take a final point from Andrew, please.
So I was just kind of going to say I would echo what people have already said, and I think hopefully Zach would share my thinking that these words, that common sense makes sense, and actually I think what I feel confidence now in having this sort of dual function of being governing body and a clinical director, and sharing both those spaces, as I feel we've got the executive team colleagues that are here, the deputy director team, commissioning managers, finance, contracting, the meds optimization team. We're really well placed to deliver on these things. And thankfully, Marion's just given us an example of such. And I think it puts us in a really good footing going forward into the next sort of 12, 18 months as things change around us, that we're sort of setting our stall in a really strong way. And I feel confident that the organisation is capable to deliver that.
Thank you, Andrew. Okay, Sandy, I think we've given the presentation lots of consideration. Was there anything else in specific that you wanted to hear views on before we move on?
No, not at all. I just wanted to come back with other comments and say we've been on a long journey, but for me, the journey is really just starting now to ensure that we can deliver and have the impact that's needed for Sheffield. We are bringing the outcomes framework to a governing body development session, so everybody can be involved in the development of that, as well as to the joint commissioning committee development session. So it really is a co-produced and detailed piece of work that we will be holding ourselves to account in order to do that delivery. So yes, even though you may have seen a number of presentations a number of times, it will be something that will be continued to be brought back to governing body to make sure that we really are delivering and having that impact for Sheffield.
Thank you, Sandy. Okay, moving us on now to item 15, paper J, which is the month 10 performance and delivery report. I'm going to hand over to Kath, please.
Thanks, Terry. And I realised I didn't introduce myself at the beginning, so I'll do that on the third item like Brian did. And so I'm Kath Tilney, and I'm the Associate Director of Corporate Services. So I'm going to assume that everyone's read the report, and I've got 3 areas as normal that I'm going to highlight. I'm going to start off looking at the impact of COVID on the acute elective backlog, and it builds on what Jackie was saying about the growing waiting list. And I've included benchmarking this time, as I did a few months ago, around the longer 52-week waits. And I think you can see in the performance report, the one consistency is that growing number of longer waits. Other things have kind of come up and down, but we just keep seeing that growing. And the acute sector's worked hard to try and keep on top of this, but it does continue to grow, and they're trying to deal with the clinical priority best they can through that. So we do recognise that for the CCG, that's a significant area of risk for us, and something that we need to work very closely with our partners to make sure that we've got ambitious and realistic plans as we move forward to clear that backlog, but also recognising that the challenges haven't gone away. So there's infection control, social distancing is still going to be here for many months to come. But I have included in the report a comparison with other similar providers, and there isn't a lot of benchmarking information around at the moment, but we do have that information, so I thought I'd share that again. So looking at that, you can see that actually Sheffield, or STH, because this is by provider, STH has always been for many years and remains one of the top performers in the country for this. We had, let me just, I've got the numbers here. So in December, STH had 386 people that have been waiting for more than 52-week waits, which is count as or we have traditionally counted as a longer waiter. I think that, I'm not sure if that's going to carry on being the measure as we go forward, but that's 386 for STH compared to Hull, which is the worst in the table, that's at 9,355, just in a completely different ballpark. And you can also see in the table that the SYB providers generally are just significantly lower than the others. So that does show, although we've got a big job on our hands, we have got a very strong system, and they're doing really well considering the circumstances. So we should be in a good place to deal with that as we move forward. The next thing that I wanted to highlight was linked to the section we have on working with and supporting our staff, and what we're doing to help prepare for the transition and integrated care and moving to a new organisational model. We have, since COVID, we've been having regular fortnightly staff briefings, and both Leslie and Terry and Brian have been using that to update staff about what's going on, and that's been really helpful to be doing that. And we've wanted to make it really clear to staff that this is something we're going to do with them, and that they'll help us as we move into that new world. There's a piece of work that the whole organisation is working on together, both in teams and as individuals, and we're taking the time we've got now before it all kind of happens to make sure we've logged everything that we're doing. So we've got some really good, strong information to take us and move forward. So we're logging functions, we're logging what each of those functions is doing, and why we do them, and what the current level of integration is across South Yorkshire and Basset Law. And the aim of this piece of work is to make sure we've got a strong information basis in order to inform those future models, but also make sure that we don't accidentally miss any body or any function that's really key as we move forward in the process. So all our staff are contributing it, but when that final product is there, all staff will be asked to make sure they can see themselves in it, so we know we've got all that recorded. The process that we've followed, we've shared with other SYB, CCGs, and with the ICS, and they're all in the process of doing it as well. And then we're all going to come together and see what it looks like, so that should be quite interesting. And then the final thing that I wanted to highlight was the relatively new section we've got on inequalities at the end of the report. And within this, for the first time, this engagement team have added in some of the work that they're doing for inequalities. It might be a bit repetitive to a certain extent that we've built this in another place. We thought it'd be quite useful to just show and give that assurance in this report as well. So we will include that on every so often as well. So we're going to use this section to just provide different bits of assurance around inequalities over the year. And there's also an update in there around the work that we're doing on assessing data quality around inequalities and the characteristics that we want to make sure that are there in the data so that we can use it to inform our plans and understand the impact of what we're doing. So I think that's covered the main things that I wanted to highlight.
Thank you, Kath. So this is a paper coming for consideration. Are there any points or questions governing body have for Kath? Mark Gamsu, please.
Right, sorry. Yeah, I flagged this up earlier. I mean, I welcome this, and it's very accessible as well, I think, and it's honest about where we are. The section on inequalities, which we have looked at before, because I think this is the second time you presented this here, Kath, is still got a huge amount of red in it in terms of looking at data that's actually being collected, and particularly in the light of the discussion we had with the patient story at the beginning. I think that continues to be of concern. I mean, I'm not an advocate for overwhelming organisations with data collection, but it does seem that if we're going to keep an eye on where we are and organisations can't assure us that they're gathering that data, that is an area of significant concern. And also, and I apologise if I asked this last time, but it looks at the big foundation trusts, but it doesn't pick up on general practice data. Now, maybe that's because that's going to the Primary Care Commissioning Committee, but just assure me on that, please.
Yeah, we're working our way through the data sets. So I think it says at the end more data sets to be added, and we're just working through a process. So we will look at all our data sets in those terms. I hate to disappoint you, but I think you'll find that the acute ones have got a lot more in than some of the others have. So we might find that some of our richest sources of data is that, but they are nationally defined as to what they have to collect and what they have to give to us. So that's something we'll need to think about as we move forward. But there's a lot of our data sets have even less in, unfortunately.
Okay, and my question about general practice.
So we will be adding that into the tape. We will be doing that piece of work. We just haven't got to it yet. So our plan is to just keep doing it. We're just working our way through a process. So it will be added in, and we'll share it with you when we've got that.
Thank you, Kath.
Thanks. Lee Salisbury, please.
Hi, thanks, Kath, for the paper. It was really comprehensive and understandable. I've got two questions which are completely unrelated. So I'll give you them both and see what you think. The first is, and I don't know how well you'll be able to answer it, but just thinking about the backlog that we know is building up, whilst acknowledging that it could be a lot worse, and obviously it could be a lot worse, and those numbers are hugely different to elsewhere, which is good. It's still a significant number, and being mindful of the fact that pre-COVID, there always seemed to be a struggle to keep on top of waiting lists and referral rates. I'm just wondering if you've got a sense of how up for change and doing things differently the system is. And I don't mean just in terms of doing the old things differently, so remote consultations for outpatients and all the rest, but actually transforming the way that referrals happen, the way that GPs can talk to consultants. You know, there could be a completely different way of doing health going forwards, and that interface between primary and secondary care. And now would seem a really fantastic opportunity to look at that, but I'm not sure how open to that degree of change both primary and secondary care would be, given that everybody's struggling and getting through the crisis. But so it would be a really fantastic chance to really look at how we do health, and and also meet the needs that are going to be out there and that are already out there. So just a bit of a sense of that. And then my second question, if I can just get the paper up, was just looking at the Sheffield CCG Health Check report, which is item 2.3 on page 16. I was just a bit concerned about the question around culture within the organisation. And the comments there that actually maybe the culture hadn't changed as much as we thought it had, it's still bad in pockets, and asking what the CCG is doing to address bullying in a virtual culture, which was just very sad to read. And obviously I don't know whether that's just one person or it's a number of people, but the fact that it's there is really, really important, because I absolutely know how much effort and work has gone into shifting the culture and having things very, very different, and including staff and listening to staff. So just a bit of clarification on that point would be really helpful. Thank you.
Okay, thanks.
So thank you, Lee. I'm probably going to try and help you out a little bit here, Kath, because I think some of those questions they're really quite big. So the question about sort of the appetite for provider collaborations and doing things differently, if I may probably bring Brian and Leslie into some of those answers there, so that you're kind of not on an island answering those. And then in terms of the data that's coming through that temperature check, again, if you and Leslie could provide a joint stance on that, that would probably be very helpful.
Thanks, Terry.
So, Leslie.
Over to me. I think there is the opportunity to influence change around what's termed as COVID recovery and reset. I think there's currently work going on which focuses around clinical prioritization for treatment and harm minimization. There is work to continue to embed what's happened around virtual consultation. I think what you flag up to us, Lee, is actually there might be potential to go even further. And therefore, I think what I'd like to do is take that away and think about how we place that in the relevant system-wide work that's happening, and indeed in some of our own local, for example, elective care, long-term conditions, transformation programs.
And I think I'd sort of echo that, Leslie, in terms of the work stream that we've got, particularly around planned care. There is an appetite to do it differently. I think it started to lift its head back up last July and August as we came out of wave one. It sort of went back down again, and it's now the language is for it to start coming back up again and think differently. So I think the appetite is there. It's building on the experience that we have gone through as a set of organizations working together through the COVID experience, to be able to, as Leslie said, if there is an opportunity to take that even further, let's harness that in the space that we're now occupying.
And if I pick up on the culture points, I think like you, Lee, it was a heart sink moment to me to read comments that thought that our culture hadn't changed. And interested because I do get many, many more that do express, and indeed in writing and things that people say, how they feel that there's a palpable difference in the culture. However, if no matter the numbers, if that is individuals' experience, then it is up to us to continue our efforts, if not double our efforts, to work on that. So we pick what comes out of the temperature check, and then we start on what we call our thoughts and our actions, and then feed back to staff brief on the additional things that we're doing. So from last time round, things that we picked out were around that feeling that sort of individuals felt their mental health and well-being had just come down in scores, possibly to be expected in terms of January and third national lockdown. So we've been doing some work on that. And the next theme I think you'll pick up is those views around culture change and virtual bullying.
And I'd add to that as well, that we've part of the issue with the temperature check is if you get a comment like that, you want to know what it's about, and it's difficult because obviously it's all anonymous. So one thing we've said we'd do is bring the temperature check feedback alongside Freedom to Speak Up guardians, and encourage people that if there are issues that they do raise them. So we'll try and bring those two things together and just recognise that if someone says something like that, we can't do anything about it if we don't know where it's come from. So try and encourage people to raise things as well.
Yeah, and it is challenging because on the same day I read that, and that was a heart sink moment, I had a letter from someone who was retiring, having been in the NHS since 1972, and expressing that the last couple of years in Sheffield CCG had really been the best. And extolling the culture that we have. So it's a difficult balance to strike, but any feedback is good feedback and something for us to pay attention to.
Absolutely. Chris Neild, please.
Yeah, thank you for this. It's a really useful document, and you know, also the impact of the work we've got to do in this situation. I was going to raise a similar point to Lee, really, about the digital and the remote appointments and so on, and really building on that so we can share the learning and do it differently, but also really mindful of some of the inequalities there and how we're proactive with that. I was really impressed with the digital strategy program that we heard about last time, and just wanted to, you know, echo the work around, we need the work around that, and also think about it in terms of people that are really isolated and how we can be proactive with that, not just the access issues, which may, you know, it may even widen the gap for people that are asking for it, are still not necessarily the people that have had the most need. So I just wanted to emphasize it. I can't, it wasn't in this document, I don't think, some figures in an earlier one, which showed how many appointments compared with last year, which you would expect, but it's still how people have made really good use of that. And that's got to be something about engaging people in their own treatment and, you know, opportunities for discussion. So yeah, that was it really. It was just those points.
That's helpful. That I've got an action from that, the digital session, to come back to governing body with a plan, and we've got a meeting next week where we're going to discuss that, and I'll take it to our senior management team, and then we'll be coming back here. So thank you.
Thank you, Chris. So it's watch this space. Thanks, Kath. And final point from Judy, please.
Hi, thank you. Yeah, really helpful paper. I just want to pick up on the health inequalities, and I know Mark's already sort of made a comment around this, Kath. I think with the patient story, particularly in all of our minds, I probably want to suggest that, Alan, we look at this and discuss this in more detail in terms of the fact that disability / additional needs is kind of not happening really in outpatients and A&E. There's no data around that, and then in inpatients it's only partially being met. That's one aspect, and as we've heard, the recording of it is one aspect. The fact that organisations like those should be making sure that they offer reasonable adjustments if they don't know or are not asking if people have got additional needs, disability, then, you know, how's that going to become embedded change, that cultural change that we need, that we heard from the patient story. So I think it's a suggestion, Alan, that we perhaps need to take this sort of data and discuss it from a quality perspective, and then think what the actions need to be, perhaps into the quality committees in the provider world.
Yeah, happy to support that.
Thank you, Judy.
Yeah, there might be a difference between the information that we receive as commissioners and the information they hold on their system and use to manage patients. So this is our commissioner received information. I don't know that, but that
Yeah.
might be different.
Yeah, I mean, that's a good point. We need to understand, don't we, first of all,
Yeah.
it's an issue in terms of getting the information, because that's one point, and then what are the experience and the outcomes, and we've already heard one that's not acceptable.
Absolutely.
Okay, thank you everyone for reflections and comments and questions back on that paper. So I'll take us on to item 16 now, which is an oral update on patient safety, quality and experience. And over to Alan Windle, please.
Thank you, Chair. I think I will start with the collaborative work excellent collaborative work that's been undertaken between the CCG and the local authority with the respect of care homes, both from a visiting perspective and outbreak management. It's really fantastic work that we've done here in Sheffield collectively, and obviously including public health when I say the local authority, which is really supporting our care homes and our requirements to support this really vulnerable group. We've had some really fantastic outcomes there. There is some ongoing escalations from a safeguarding perspective in some of our homes relating to from families' perspective, and we continue to work again with the local authority safeguarding boards to support and our safeguarding groups to assure that the population is safeguarded, and they are ongoing. Another highlight from a safeguarding perspective, governing body, is a piece of work that was picked up by our safeguarding team at the beginning of the pandemic, which is supporting from a clinical assessment perspective for adoptions and fostering panels. Our team are no longer allowed to support from an adoption perspective, but the impact on work, which didn't cease in September, continues to have a massive impact on the team, and both myself and the Deputy Director of Quality is working with the local authority to look at how this could be managed differently, given the impact on primary care at the moment and primary care colleagues not able to undertake this work. I think we'd all agree that it's really important that we do fostering and adoption assessments as a priority to be able for children to be placed, but it is a big impact on the safeguarding team currently, and so we're working at pace to try and resolve that. I suppose the main another main issue with safeguarding is a piece of work that we are supporting the Sheffield Health and Social Care Trust with relation to supporting some governance processes in the trust, and we've got a member of our team working 2 days a week with the trust to develop governance processes. That's working really, really well, and a number of independent advisory work is also being undertaken at the request of the Care Trust regarding serious incidents, complaints and safeguarding, which again is a very proactive piece of work on their development and improvement programme since they received their inadequate outcome. And I think finally, as a quick update for this governing body, is our continuing healthcare work. I want to put a shout out to our team because they have absolutely achieved what was set out at the beginning of the programme and achieved the backlog of assessments. I think bar one, which is a little bit more complex than anticipated, we've achieved the target, and it's absolutely brilliant news. Still a lot of work to do from a recovery perspective through the pandemic and what that caused us, and some workload that was there prior to the pandemic. But again, I just want, particularly from me, I know governing body agrees that that's an outstanding bit of work that they've achieved in this period of time. Happy to take any further comments, Chair, and apologise for the short update this month. It was because we had the development day at Quack on the last session, but just to assure governing body we continue to exercise our duties in quality assurance, given the restrictions on the COVID restrictions on the pandemic. So thank you.
Thank you, Alan. Any questions or comments for Alan on that comprehensive update? Another one has escaped. Well done, Alan. Picking up on the point, will you pass governing bodies thanks on to the CHC team and all of those people that have been involved in turning that piece of work around for the CCG, and in fact for the benefit of people who are in receipt of those care packages. So thank you, Alan.
Thank you.
Okay. Next item on the agenda. So we've going to now move on to some updates from our accountable officer. We've got item 17 and item 18, which Leslie, you probably want to sort of take them as a bit of a package. So we'll take item 17 and 18 together. Thank you.
Thank you, Chair. And I think I topped the poll for poorest performance by introducing myself right at the very end. So Leslie Smith, Accountable Officer. I am conscious of time, so I will be brief with these and just try and pick out the key points. But I think it would be remiss of us not to reference the NHS England and improvement response to their engagement document, their recommendations to government for legislative change, and the white paper and proposed legislative change to go before Parliament in the next few months. So what I have included in the papers for governing body members and for members of the public and staff who are joining us this afternoon is a presentation that summarises key points from the white paper, which I think is a very useful sort of stake in the ground, and the frequently asked questions. So that compendium of questions, which just pulls out what does this actually mean for us and how will it happen. So going back to the white paper itself and the key points, and again, very briefly, I think just to note integrated care systems, which from 2016 have been partnerships. The legislation will be to put them on a statutory footing. And two important things from that is the concept of an NHS ICS board, or the statutory authority, which will plan for the delivery of healthcare services in South Yorkshire and Bassetlaw. And sitting alongside this, a wider health and care partnership, which will bring together the NHS, local government and a range of wider partners, including the voluntary sector. The establishment of that health and care partnership, which I think is an important thing to pay attention to, because we're all familiar with statutory boards and how they operate. But the partnership will be underpinned by a duty to collaborate, both in the NHS, on commissioners and on providers, and on local authority partners. So I think it's quite interesting. There may be a lot of opportunities in that just to be cited on. And indeed, in the last few weeks, taking this to the Joint Health Overview and Scrutiny Committee that brings together the chairs from all the scrutiny committees across South Yorkshire and Bassetlaw. Actually, this was the thing in the legislation that quite excited them, how they bring this partnership board together and how it influences and shapes what we do and the way we take things forward. So another thing to pull out is Section 75 of the Health and Care Act 2012 will be repealed in the legislation. And it's important to mention that that's not our Section 75 agreements for pooled budgets from the 2006 Act. Instead, this is the legislation around procurement, patient choice and competition regulations that have been with us since 2013. So that will be repealed and replaced with what is termed as a new procurement regime. So probably a more collaborative approach. I think that's important to mention. And the other thing that's important to mention here on the face of the bill and through the proposed changes is a reinforcement that the responsibilities of commissioners, funders of care, planners of care, and providers of care will largely remain unchanged. That the statutory functions of CCGs in terms of commissioning will continue and will be transferred to an ICS. And I think that's just important to emphasize, because sometimes I think we lose sight and think it's commissioning that's going, but actually it's the nature of commissioning that's changing and moving to a more collaborative approach. And I think that's important to emphasize. And the other key thing to highlight from the legislation is that the white paper doesn't reference changes in social care or public health beyond the duty to collaborate, but highlights that they were likely to come forward in terms of change programmes or legislation later in the year. If I can draw governing body members' attention to the frequently asked questions, and again, I think the really important thing to pick up from in there is that the way this will happen and the way ICSs will be established is by the transfer of the accountabilities and functions of CCGs. So there will be a large commissioning component to ICSs, but they will have wider responsibilities too. The essence of ICSs is about subsidiarity of place and delegation to place. And again, a really key thing in the frequently asked questions is, what does this mean for our functions and for our staff? And I think importantly in there is the commitment to minimise uncertainty for staff and to have a smooth transition to the new. And I know they're actively exploring how this can be done, avoiding dissolution and re-establishment of new bodies, so building on some of the experience from before that's happened around PCTs and health authorities. Actually, can we do this in a simpler way and have a smooth transition which reflects a repurposing rather than a dissolution? I think that will be challenging because of the nature of how bodies are constituted, but I think it shows the spirit of intent to have that smooth transition wherever possible. The document is quite clear that in minimising uncertainty and giving as much certainty as possible to our staff, the process that will be followed will be that staff will transfer to the ICS. So the ICS will become the employer, and building on that subsidiarity of place, that would be underpinned by strong place-based teams. So Team Sheffield working in Sheffield alongside our partners in local government and alongside our providers in terms of transforming care. So we have been clear with our staff about that process, about the employment commitment around terms and conditions, and about the fact that the original reference to April 22 has now been removed. And I think that's quite important because I think it's fair to say there are some high anxieties within our staff about what this means in the prospect of organisational change. So I'll pause there for breath and then happy to take any questions.
Thank you, Leslie, for that helpful update. I'll open up to questions, but just put it in the context that governing body is having a development session around this, and there'll be lots of questions and the opportunity to ask questions later on. So if we can focus our questions on really what's important for our public meeting, that will be really, really helpful. So over to Mark first, please.
Yeah, it's just clarity, Leslie. Duty to collaborate. So the assumption I'm making there is the duty to collaborate really can only be applied to statutory bodies. So that's why it's NHS organisations or local government. But presumably the duty of collaborate would include a duty to collaborate with non-statutory bodies, or is that your understanding? So in other words, general practice and the voluntary and community sector?
Yes, so the duty to collaborate on the ICS will be to invite those partners into its health and care partnership. But there will equally be, as you said, the duty to collaborate on the statutory organisations. And that's really interesting because it's where do we put the interests of populations and wider interests above organisational interests. So it's trying to remove some of the barriers to change that have stood in our way.
Thank you. Any further questions? No, thank you, Leslie. Move us on now to part 5, which are the reports circulated in advance for noting. Are there any comments or feedback that anyone wishes to raise on any of those papers? No, thank you. Item 20, any other business? I've not been notified of any other business in advance. I think that's it. Andrew, your hand went up and down. Is it?
It was a typo. It was a typo in your report, Chair. It says you've been described what you've been doing in February 2020.
Thank you. Yeah, it's definitely from 2021. So thank you for updating me on that. I haven't put forward a historical archive, and we'll get that corrected for the documents as they go out. Thanks, Andrew. Okay. So I'm aware we are slightly over time, but I do find that as we get to the end of these long meetings, it is still helpful for us just to reflect on what we've heard, what we might do differently, and what it is as a governing body we will go out and tell people about what we've discussed today. So in the interests of keeping us within time, if I could take one GP and one lay member and one executive, that would be really helpful. So any GPs want to volunteer? Andrew.
Go on then. So I will take away the quiet, calm resolve with which we understood Jackie's financial challenge in her plan for the coming 12 months, and a complete lack of panic and more a sense of determination to rise to that challenge.
Brilliant, thank you. Any of our executive team want to add anything? Okay, we've got lay member hand up, so we'll go over to the lay members while the executives work out who's going to reflect. So over to Chris, please.
I think there's been such a lot in the meeting today, hasn't there? But a real sense of collaborating across the city with, improving health and tackling health inequalities at the start of it, but a way forward to do that and to measure it. So I feel really positive about what we're doing and how various pieces of work are coming together. So that's my reflection from today.
And thank you, Brian, for volunteering for our executive team. So final reflection from Brian, please.
It just builds on what Chris said about the strength of partnership and the strength of relationship. And what brought it home to me was Marion's example of how working with the local authority in terms of our family planning services and those real tangible bits where collaboration can show how we can actually start to deliver change for the populations of Sheffield.
Thank you, Brian. So that leaves me to bring the meeting to a close. The next meeting of governing body in public will be on Thursday, the 6th of May at 2 p.m. and details of that meeting will be circulated on our website in the usual manner. And as previously mentioned, we will continue these meetings online until such time where it is safe for us to discontinue that. So I will hand over hosting of the meeting to Lucy to finish our live streaming.